Good afternoon. Okay. Good afternoon to all speakers and all NGM 2021 participants. Welcome to the IGS APGS joint session. My name is Dr. Firna and my co-moderator is Dr. Arini. During this session, we will view the following presentations. Prof. Ong Tin with imaging for angle closure. Dr. Fang Sengkyong, management of acute angle closure. Prof. Visani Tantisevi with laser treatment of angle closure. Professor Clement Tam, the role of lens extraction for angle closure, and Prof. Yudi Artini about the comparing phaco and phacotrap in the management of primary angle closure glaucoma. At the conclusions of the presentation, we will have live Q&A with all the speakers. You can type all of your questions in the Q&A box. We will now start the session, and we do hope you will enjoy the presentation. Please.
Hello, my name is Tin Ang and I'm from Singapore. I'd like to thank the organizers for inviting me to give this talk. I have no financial disclosures. Angle closure glaucoma is an important form of glaucoma worldwide, especially in Asia. It affects about 30 billion people. It's different from open angle glaucoma because the main problem is the angle abnormality, and this causes the resultant glaucoma. Thus, we need to make the right diagnosis by assessing the angle correctly. And this is where I'll be speaking on this morning on the use of imaging technologies to assess the angle. Broadly, the role of imaging in angle closure glaucoma includes looking at the angle to make the diagnosis, documentation, as well as studying mechanisms, subtypes, and response to therapy. First, let's discuss how do we assess the angle. Well, the main way of assessing the angle is by doing gonioscopy. This is the method where you will put a lens on the eye and directly look at the angle structures. We know that gonioscopy should be performed for all patients with glaucoma, but we also know that many people do not do gonioscopy. And this is because there are several issues with gonioscopy. Firstly, it is very subjective and variable. It's observer dependent. It can vary according to the light conditions that you use, including how much light enters the pupil, what lens you use. The findings are often recorded in a different and non-standardized manner. And also, you need training to perform gonioscopy well. And that's why there's a need for anterior segment imaging. And the older imaging method included the ultrasound biomicroscopy, which obtains images with 25 to 50 micron resolution and in real time. The UBM is an objective way of imaging the angles and is also very useful for imaging structures posterior to the iris, such as the ciliary body. And this is the diagnosis of plateau iris, in which there is an anterior rotated ciliary process shown in B, along with an iris angulation that looks very planar and a closed angle. Plateau iris is a variation in anatomy of the ciliary body, such that it's rotated anteriorly. And this can only be diagnosed clearly by using UPM and cannot be diagnosed with anterior segment imaging such as OCT. For cases of plateau iris, we can perform iridoplasty, in which we use laser burns to contract the peripheral iris in order to open up the angle. The disadvantage of UBM are that the field of view is quite limited. The procedure requires some contact. The operator needs to be skilled to do it well, and it also can be quite time. Let's move on to anterior segment OCT. And this is a high-resolution imaging instrument that obtains cross-sectional images of the anterior segment, as you can see in the picture. The advantage of the anterior segment OCT is that resolution is very good, within 10 to 20 microns. It's non-contact. It's performed with the patient sitting up, and it's quite quick to obtain the images. When you obtain an anterior segment OCT image, we basically use subjective analysis of the image to determine it as angle closure. You can also make quantitative measures of the angle. So let's talk first about the subjective analysis. And in this picture, we have to tell, is the angle closed or not? The problem with the anterior segment OCT images is that in most images, you cannot image the trabecular meshwork directly. And so we use a landmark called the scleral spur. The scleral spur is found by following the inner contour of the cornea and the inner contour of the sclera, and they meet here at the scleral spur where the arrow is. And the trabecular meshwork just lies just anterior to the scleral spur. And here you can see the anatomy here, where the scleral spur lies posterior to the trabecular meshwork in red. So in this image, if you follow the inner curvature of the cornea and the inner curvature of the sclera, they meet the scleral spur. And you can see here on the left that there is contact of the iris anterior to the scleral spur. And this is where you assume is the trabecular meshwork, and so this is angle closure. In this example here, you can see that there is no contact at all because the scleral spur lies here and there's no contact of the iris where the trabecular meshwork lies, so this open angle. Here's another example of angle closure. You follow the inner curvature of the cornea and the sclera, they meet around here. And here you can see obvious contact anterior to the scleral spur, and this is angle closure. As I said earlier, you can also make measurements of the angle, again relative to the scleral spur, and these are including angle opening distance, angle recess area, and others. And again, these measurements are made 500 microns from the scleral spur, and this is because this is where we expect the trabecular meshwork to lie. The disadvantage of the anterior segment OCT is that we are unable to visualize the trabecular meshwork in most cases, and so we need to guess a little bit as to whether there's angle closure. There's also a limitation in that you only can see the scan of where you take the image, and if you take multiple cuts, if you don't take multiple cuts, you may miss angle closure in different parts of the eye. There's also some limitations in angle assessment software. And finally, scleral spur definition is a problem in about 20 to 30% of cases. Here's an example where there's no obvious change in curvature between the cornea and sclera. So you don't know where the scleral spur lies. It could lie here, 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 and depending on where it lies, the diagnosis of angle closure or open angle can differ. Now we move on to spectral domain OCT or high definition OCT. So as you know, for retinal imaging, OCT is now using spectral domain mostly. And again, with anterior segment as well, you can obtain high resolution images of the anterior segment, as you can see here, where you can see the Schwa-based line, you can see the trabecular meshwork, as well as scleral spur. Here's another example where there's obvious angle closure between the scleral spur and trabecular meshwork area, where there's iris apposition. The current main spectral domain OCT device is the Cirrus anterior segment OCT. And here's an example of a Cirrus image. And this is obtained by putting an adapter lens on the Cirrus machine, which is used to image the posterior chamber. And here you can see an adapter, which will then convert the OCT from a retinal imaging device to an anterior segment imaging device. And there's some processing which is done by the Cirrus. And you can see here, it basically removes the reflection of the anterior segment structures. And that's why you may sometimes see a blue band in the cornea, and this is due to the reflection that was previously present in the image. And this is then removed by processing. The Cirrus anterior segment scan you can obtain different cuts by rotating the axis. And here's an example. And if you compare the Cirrus with the Visante, you can see they look quite similar, maybe slightly brighter with the Cirrus only. And of course, sometimes they have this blue band in the cornea. The Cirrus also has a wide scan, an angle-to-angle scan, which measures looking at more high resolution of the anterior segment angle only, but not the whole cornea. Now let's move on to swept source OCT. And this is the later device, which is much faster. It obtains 30,000 A scans per second. And also is useful because you can obtain 360 degrees of the angle of the entire eye imaging. This is the CASIA or the swept source OCT high resolution scan. Again, you can see the Schwa-based line, scleral spur, as well as the trabecular meshwork. This is a very nice 360-degree gonio view, which is very useful to look at it in high resolution. The scan I like is this scan, the 360-degree angle imaging scan. And here you can see the arrow going around. So basically, it's taking multiple images of the anterior segment. And here you can see starting off with horizontally, they then take 128 consecutive images as they look at the arrow moving around, and then it will reconstruct it as a video. And so you can see multiple cuts of the anterior segment here, as you can see here. So basically, you will see 256 angle images from 128 sections. The service is useful to locate peripheral anterior synechia, and this is by using the inbuilt software. But the main role of all these imaging devices is really to help you make the diagnosis and to document what you have found so that when you treat the patient, you can show the patient what the patient has and how the patient responds to treatment. We also have been using imaging to look at new risk factors for angle closure glaucoma, including the iris thickness and area, anterior chamber width, area and volume, and lens vault. So here we can see here, for example, we found that the iris thickness is an independent risk factor for angle closure. It makes sense. The thicker the peripheral iris or the more bulky the iris, the higher risk you have for angle closure. We also found that anterior chamber width is a risk factor for angle closure. So not only the depth, but also the width. So basically, eyes which are smaller in cross-sectional diameter will also have more crowded anterior chamber and be higher risk for angle closure. Finally, we found a risk factor, very important risk factor called the lens vault. And basically, it's formed by, if you draw a line from the two scleral spurs, it's the part of the lens that lies anterior to this line. And this is the lens vault. It's different from lens position and lens thickness. So it only represents the part of the lens that's jutting into the anterior chamber. And we found that this is a major component of angle closure in many cases. So these studies have shown that angle closure glaucoma is not a homogeneous disease. There are different subtypes of angle closure according to the different risk factors present in the patient. And the anatomical risk factor may vary in different people. So this is a study we looked at where we tried to ask the question, are there subtypes of angle closure based on anterior segment imaging? And we actually found there are three subtypes. The first subtype are the people with a very thick iris. The second subtype are the people with a large lens vault and a small anterior chamber. And the third type is mixed mechanisms where you have a variety of anterior segment abnormalities that cause angle closure. Obviously, if you have the second subtype with a large lens vault, you should do lens extraction. As I mentioned to you earlier, imaging is also very useful to document changes to response to treatment. So here's an example of a patient with pupil block documented by UBM. And after laser iridotomy, you can see the pupil as the angle has opened and the anterior segment has become much deeper because the iris convexity has decreased. Here's another example where the patient has responded to the LPI on the top example. Here you can see after LPI, iris convexity is decreased and angles opened up. But in the lower example, you can see no change after LPI. It is also useful for documenting treatments such as phacoemulsification. In this example here, after LPI, angle opened up slightly, but still very narrow. You can see due to a very large lens vault. And after phacoemulsification, the lens has removed the anterior chamber much deeper and angles have opened up. So in summary, there are different methods, objective methods of imaging the angles and anterior segment. These are very useful for diagnosis, for documentation, understanding mechanisms and risk factors, as well as response to treatment. Thank you for your attention.
Good afternoon, everyone. I'm Dr. Seng Kyong Fang from Malaysia. Welcome to the 8th National Glaucoma Meeting organized by PERDAMI and the Indonesian Glaucoma Society. First of all, I would like to thank Dr. Asranda Suroyono and Dr. Ike Sumantri for inviting APGS to join in this meeting. My topic today is management of acute angle closure crisis. I have no financial disclosure to make. Management of acute angle closure crisis can be divided into making a diagnosis, immediate management, doing a laser iridotomy, and surgical management. in the interest of time, I will be concentrating on immediate management. So how do we manage acute angle closure crisis? First, we must determine the cause. And nowadays, primary causes are less common now, but we must be always aware of secondary causes such as subluxated lens. And we will try to go through the initial management of the acute angle closure crisis, which is to break the attack that is normalizing the intraocular pressure reduction rapidly, either by medical treatment, laser iridoplasty, and I will also mention anterior chamber paracentesis. And I will need to emphasize that the definitive management of acute angle closure is still laser iridotomy. And sometimes we do lens removal by phaco emulsification if the patient has significant cataract. And always remember to treat the fellow eye with a prophylactic laser iridotomy. And remember to regularly follow up these patients to check their intraocular pressure, angles, and be aware of plateau iris. And also, some of these patients will progress to chronic angle closure glaucoma. So the main goal of treatment of acute angle closure crisis is to break the acute attack, that is to normalize the intraocular pressure rapidly as possible. This is mainly needed because we want to prevent structural and functional damage. Structural damage referring to the trabecular damage, formation of peripheral anterior synechia, and also further lenticular damage. And functional damage refers to the optic neuropathy. And as I mentioned earlier, we need to prevent recurrence and progression to chronic angle closure glaucoma. If we can break the attack as soon as we can, then the incidence of progression to CACG will be less. So how do we break this acute attack? Traditionally, most of us use medical treatment, but sometimes depending on the onset of the attack and the duration of the attack, medical treatment may not be able to lower the intraocular pressure as fast as or rapidly as we want it to be. And studies have shown that laser iridoplasty can even be used as a primary treatment. And if we don't have a laser with us, then we can even do anterior chamber paracentesis. So for medical management, we can use the traditional anti-glaucoma drops such as alpha agonists, PGAs, beta blocker, CAIs, and cholinergics. Word of caution here is do not use 4% pilocarpine. We can use 2%, because if we use higher doses of higher concentration of pilocarpine, we can induce lens iris diaphragm to come forward and aggravate the acute attack. And always remember intensive corticosteroid to reduce the inflammation to prevent further complication. And if all these medication do not work, we can try oral or parenteral acetazolamide or even intravenous mannitol. And I will be mentioning later that these systemic drugs can cause side effects. So what are the problems with medical management alone? It has been shown that they may fail to reduce intraocular pressure in up to 30%, depending on the onset of the acute attack or even the duration of the acute attack. And you can have experienced before that this medical management can be slow to reduce the intraocular pressure and sometimes may need to take up to days. And systemic side effect, especially for the systemic drugs such as acetazolamide and mannitol, can be serious, especially in patients who are medically compromised. And as I mentioned earlier, 60% may still progress to chronic angle closure glaucoma. So the trend nowadays is to institute medical treatment usually for up to 2 to 4 hours after the attack. And if the attack can be aborted, then we can proceed on to do a laser iridotomy. As I mentioned earlier, always be cautious when using this systemic medication, as they can cause potentially fatal side effects. Professor Clement Tam and his group has actually did a study on iridoplasty and paracentesis early to reduce the intraocular pressure rapidly to prevent structural and functional side effects. Professor Clement Tam is also here uh, in this symposium, and later during Q&A, you can also ask questions to him. So laser iridoplasty can be used as a first-line therapy at presentation, and I will show you a video by Robert Rich on the laser iridoplasty. Laser iridoplasty is to cause a contraction burns of the iris so that it can pull away the iris from the angle. As you can see, the spot size here is a large spot size, 500 to 1000 microns, long duration of 0.5 second, and start with low powers such as 250 milliwatts. Normally, we may need to start more at the periphery when we initially start, because sometimes we could not see uh, the iris or the angle very well. But once you have contraction burns and the iris is pulled away from the angle, cornea clears up, we can then move slowly to the periphery, as we can see here. And make sure that you don't start too much to the center. Coming to anterior chamber paracentesis, it can be effective and can produce immediate normalization of the intraocular pressure, and thus possible reduction in irreversible optic nerve head damage. So if you do not have especially laser equipment, you can use a paracentesis to rapidly abort the acute attack. And this can be done at a slit lamp. It is done under topical anesthesia. I prefer to use the 25 gauge needle, or you can even use the 15-degree side port knife. And most surgeons are familiar with this procedure, as we are, most of us are phaco surgeons. But beware of this potential risk of AC paracentesis. If you release the aqueous too fast, then you have a chance of getting decompressive retinopathy, choroidal effusion, and even choroidal hemorrhage. So the release of the aqueous must be slow. And because the anterior chamber is very shallow, the procedure can potentially cause damage to the iris, the lens, and cornea endothelium. So if the anterior chamber is very shallow or flat, I would not recommend this procedure. And infection is rare, and be aware that with paracentesis, there can be aqueous misdirection or malignant glaucoma. I will go through this flow chart for us in two scenarios: patient with acute angle closure without cataract and with cataract. So once the patient presents with acute angle closure crisis, we will normally try medical treatment to see whether the acute attack can be aborted. If it is aborted, then we proceed with the laser iridotomy. But if medical treatment cannot lower the intraocular pressure rapidly, we can proceed to either ALPI or even paracentesis. And once the acute attack is aborted, usually it can be aborted with this either ALPI or paracentesis. Then we will proceed to laser iridotomy. And once the laser iridotomy is done, patients recover and we need to follow up the patient. Rarely, if paracentesis or ALPI does not reduce the pressure immediately, then we might need to proceed to immediate phacoemulsification. But this can have problems, especially in acute inflamed eye. Previously, if we do not have ALPI or paracentesis, patients who are medically uncontrolled will need to proceed to have a trabeculectomy. But again, trabeculectomy in patients with acutely inflamed eye can be potentially cause more complications and failure. So we mainly be able to prevent trabeculectomy in acutely inflamed eye. Again, just a reminder, once the iridotomy is done and patient recover, we need to follow up to make sure that we can pick up chronic angle closure glaucoma. And if the glaucoma still progress, we later on may need to proceed with a trabeculectomy or even a phacotrabeculectomy. The second scenario is patients with acute angle closure and cataracts. If again the medical treatment abort the acute attack, then we can proceed with phacoemulsification. I would mention later the problems with phacoemulsification in my next slide. And if we cannot control the intraocular pressure medically, we can proceed to iridoplasty or paracentesis, and this usually can break the attacks. And if the patient has recovered, then we can do phacoemulsification. But rarely, if we cannot break the attack with ALPI or paracentesis, we might need to do immediate phacoemulsification. And again, once the patient recover, we have to follow up this patient to look for chronic angle closure glaucoma. And if the patient still progress, then we might need to perform a trabeculectomy later on. Coming to phacoemulsification, if I mentioned earlier, if we do in the acute stage, there might be more complications. So normally after intensive corticosteroid, about 5 days, the inflammation is settled, then we can proceed to do the phacoemulsification. Always beware of a shallow anterior chamber. Use a lot of viscoelastic to protect the cornea, and sometimes we might need capsular staining and also mechanically dilate the pupil if the pupil is small. And as I mentioned earlier, always be aware of subluxated lens and have capsular tension ring ready, because if the lens is subluxated, we might need to insert the CTR. And again, always be aware of aqueous misdirection and have measures to prevent that. And post-operatively, intensive use of corticosteroid. The subsequent management is always to treat the fellow eye with a prophylactic laser iridotomy and follow this patient up regularly, check their intraocular pressure, perform regular gonioscopy to look for PAS, and also assess the optic disc and visual field to look for progression. So the take-home message for my talk is that acute angle closure crisis is a ocular emergency. And the goal of therapy is, again, as I mentioned earlier, to lower the intraocular pressure as quickly as we can to prevent structural and functional damage. Iridoplasty can be used as a first-line treatment. Normally, I would advocate that this procedure to be used as early as possible and not to wait too long. Paracentesis is an option if the laser is not available. And definitive treatment, again, is laser iridotomy and also for the fellow eye. And lens removal is a viable option if everything else fails or if there is a significant cataract. Thank you for your attention. I would like to invite you to come and join us next year at the 6th APGC, 5th to 7th August 2022 in Kuala Lumpur, Malaysia. Thank you for your attention.
Hi everyone, I'm Isney from Bangkok, Thailand. The topic I'm going to talk today is laser treatment for angle closure. It's so nice to meet you all here, and this is my financial disclosure. Primary angle closure can be classified into three groups: PSCS, PSC, or PSCT, as we already been recognized. By the way, mechanism has to be something to mention in the beginning, because the angle closure mechanism can be PP block or non-PP block. But the PP block is the most common thing. But after it has been eradicated, it can be mixed. So the basic principle of treatment in angle closure is something like a modified angle configuration to correct the mechanical blockage. This is the first thing that we should do. Where is the role of laser in PSCD? With this flow chart nicely showed, we have modified from Professor Tham. It can nicely show that the laser adoptomy endoplasty can be, the initial procedure for the PSCD, whether or not you will do something else, just like lens extraction. This is in the acute setting. The medical procedure can be started, but anyway, whenever possible, please put the LPI as the first treatment option, because this one can break PP block, which is the main mechanism of acute angle closure. How about the chronic angle closure, glaucoma? Yes, of course, the LPI is still the mainstay, because we have to eradicate or get rid of the PP block before we consider whether there are other mixed mechanisms involved in this angle closure. This is the eye scheme that shows so nicely where the laser can be done. Usually we use the iridotomy for the trabecular iridotomy or endoplasty to release the internal flow block. The laser iridotomy is something that we are most familiar with. The indications is absolute in the PP block mechanism, whether in the Q or others. However, in the PSCS eyes nowadays, the role of the iridotomy is still under debate whether or not it should be performed in every cases with the PSCS. When you do the iridotomy, some cautions needed, because in eyes with risk of bleeding, you can cause the hyphema or the hemorrhage, or the eyes with the poor visualization with significant corneal edema. The iridotomy will not be successful, or somehow you can do the corneal injury. So the outcome, as I just mentioned, this is to widening the angle, because we can eradicate the PP block in these eyes. However, the failure can be, can be encountered if the peripheral iris is too thick, the anterior chamber is not adequate enough for the corneal edema as well, which means the poor visualization of the site of the iridotomy. Apart from the hemorrhage, the corneal burn can be encountered if you do not properly, put the laser beam on site. You can have the decimate crack as well, or somehow you can cause the lens damage. The complications in the long term that we all usually heard about it is the closure of iridotomy or the corneal decompensation. This can be encountered from time to time, but usually with the laser performed through the argon laser, it's not usually found in the pure YAG iridotomy. So please be careful about it with the argon. Some study that makes about the curiosity around the world, whether should prophylactic LPI be used extensively for the PSCS. So the PSCS eyes has been included in this study. The patients, yes, of course, one eye of the patient do the LPI and one eye for the observed. The primary outcome is the composite outcome of the PSCS, the active rise up, and acute angle closure. And they found that in the untreated eye of nearly 900 eyes, only 36% that has meet the primary outcome, and the treated eyes, 19 eyes of those. However, when they explore so thoroughly, they say that the frequency of primary outcome was very low. So the recommendation of the sub-study is prophylactic LPI should not be performed routinely, just only with the high-risk eyes. However, it's still under debate because this is in the Chinese side. So can it be generalizable to the non-Chinese population? The laser eye diaplasty is very beneficial for the acute setting. Why? Because it comes from the published paper in 2002 that have the idioplasty compared with the medical intervention in the acute primary angle closure. And it definitely shows that within 30 minutes after the laser, the IP can reduce dramatically when compared to the medication in the acute setting. So that's why the idioplasty is something that's very beneficial for the acute angle closure. The outcome of idioplasty in the plato iris can be favorable. In the phagomorphic glaucoma can be done favorably, but when you have to do it in chronic angle closure eyes, you need to be very careful because there's a comparison between the prostaglandin and idioplasty. It seems that idioplasty cannot do better with when compared to prostaglandin in those eyes. Complications, yes, we have to mention about it a little bit. The correctopia and the mydriasis is not, frequently mentioned, but it can happen because when you do the scar at the peripheral iris, you can pull the pupil away from the center. And when you do it extensively, 360 degrees, yes, of course, somehow permanent mydriasis can be happening. Second photocoagulation is to reduce the inflow of the aqueous. The conventional transcranial CPC is something that we know a lot. We know for a long time in the refractory glaucoma. But when we have to do it, the cyclophotocoagulation, particularly for the endoscopic CP, the blind eyes is something that we have to be very cautious because it can do the sympathetic ophthalmia happen. And in the phakic eye as well, when you have to do endoscopic CP, you might do the lens injury. This is the study that done the conventional CP in the refractory eyes, and it nicely shows that in refractory angle closure, the TSCPC or the conventional CP can do better than other type of the glaucoma because in refractory CSC, the conventional CP can have the higher success rate, can have the lowest retreatment rate and the lowest hypotony rates. Endoscopic CP can allow us to see, the CP directly or the cerebral processes directly. And with the endoscopic CP, it can cause the disruption of the cell of the cerebral process and loss of blood vessels within the stroma. That's why it can reduce the IOP. In the refractory eyes, this study shows that the ECP can do incomparable with the other alternative surgery in refractory glaucoma. So, and the post-op IOP dramatically reduced in both groups. Complications with phthisis hypotony is very few, and just only the IP spike can happen during the first or the early period after laser. Micropulse is something that we are using nowadays. It can reduce IOP by reduction of the aqueous production and enhance the UVO scleral outflow. The action of the micropulse is something different from the conventional CP, as we mentioned earlier. This is a table that compiled up of the studies of the moderate to refractory glaucoma that done with the micropulse TCP, and we find that the micropulse can do very efficacious in these eyes. The success rate is about 60 to 80%. However, its efficacy might decline over time. The complications when compared to the conventional CP seems that the micropulse can have the fewer because it can do less prolonged hypotony. It can do less prolonged AC inflammation. The selective laser trabeculoplasty or SLT can it be done in the angle closure eyes with the visible TM. This is the early study that did the SLT on the angle closure eyes. As I just once said, that with a visible TM, it seems that it can have some kind of the reduction of more than 3 millimeter mercury in more than 2/3 of the patients. And when compared to the POAG, SLT and PSCG can have the safety and efficacy that's equivalent. So in the summary, I think the laser treatment is one of the essential initial procedures in angle closure treatment. The role of laser iridotomy in PSCS now is under scrutiny. We have to, perhaps may not be done in every cases with the PSCS. The success of the laser treatment depends on our understanding of the ACG mechanism and select the suitable laser. The safety depends on the understanding of the laser nature and how well we prepare the patients and how well we prepare the method to the patients. So that's all for now, and I would like to thank all the resident and fellow who helped provide some kind of the data and some wonderful slides. Thank you so much for your kind attention.
Good day, ladies and gentlemen. I'm Clement Tam from the Chinese University of Hong Kong. Before I begin, let me thank Dr. Esrianda Suryono and the Indonesian Glaucoma Society for inviting me to participate in this symposium. Today, I'm going to talk about the role of lens extraction for angle closure disease. So first of all, these are my financial disclosures and also the government funding that has gone into supporting our research work on PACG. Let me start with a management algorithm for managing angle closure. I'm going to present to you two hypothetical situations which are at the two extreme ends of the clinical spectrum. First of all, let us look at a situation when there is 360 degrees complete appositional angle closure. Of course, this is a hypothetical situation, and there is appositional angle closure together with ocular hypertension with or without glaucomatous optic neuropathy. So in this particular clinical scenario, if there is visually significant cataract, we would perform, first of all, cataract extraction. If the angle opens after the cataract extraction, of course, we are very happy. But otherwise, if there is still persistent appositional angle closure, possibly with plateau iris syndrome, then we may consider argon laser peripheral iridoplasty for these cases. On the other hand, if there is no visually significant cataract, then we may consider, first of all, a laser peripheral iridotomy. If there is still persistent appositional angle closure with ocular hypertension after the laser peripheral iridotomy, then we would have to decide whether plateau iris syndrome or the lens being the main mechanism leading to angle closure. If it is plateau iris syndrome, we may consider argon laser peripheral iridoplasty, whereas if it is the lens, then we may consider lens extraction. Now, in the second hypothetical situation, we will have 360 degrees complete synechial angle closure. Once again, this time with ocular hypertension, with or without glaucomatous optic neuropathy. You can see that, once again, if there is visually significant cataract, then we perform cataract extraction with or without another IOP lowering surgery. Now, I think the main difference between this situation with complete synechial angle closure with the previous situation with 360 degrees appositional angle closure is that in the situation with synechial angle closure, even when you have done something such as cataract extraction to deepen the anterior chamber and widen the drainage angle, the trabecular meshwork may still not be available for aqueous drainage because of the synechial angle closure. So in this situation, you may have to consider other IOP lowering surgery in order to control the pressure after the cataract extraction. And these other options may include goniosynechiolisis, various forms of cyclophotocoagulation. It may include minimally invasive glaucoma surgery, trabeculectomy, or glaucoma drainage device implantation. Later on in this talk, I'll share with you my own personal preferences with regard to these other surgical procedures. Now, if there is no visually significant cataract, then you would have to decide whether the lens is the predominant mechanism. If it is, then you may consider clear lens extraction with or without other IOP lowering surgery. And I will share with you later in this talk what are the factors to consider whether to perform these other IOP lowering surgery. And also, furthermore, if the lens mechanism is deemed not significant, then you may consider just performing other IOP lowering procedure with or without the clear lens extraction. Now you can see that using this algorithm, very often we would have to decide whether the lens or the plateau iris being the main mechanism leading to angle closure. And how do we decide? Now there are certain evidence that points towards the lens being the main mechanism leading to angle closure. Of course, there are all these quantitative measurements we can make of the anterior segment using UBM and anterior segment OCT. But I think for the purpose of clinical management, by far the most important evidence comes from the central anterior chamber depth, as well as what I would call the Mount Fujiyama sign. Now, the central anterior chamber depth is perhaps the most important parameter. This is because the central anterior chamber depth is the combined result of both the lens thickness as well the anteroposterior position of the lens. So a very shallow central anterior chamber depth points to the fact that the lens, because of either its position or its thickness, is the main mechanism leading to angle closure. And what do I mean by Mount Fujiyama sign? It is in those eyes when you're looking from an angle at the iris surface as well as the pupil and the lens, anterior lens surface, it takes on the appearance of a volcano. You can see that in this particular eye, it looks very much like Mount Fujiyama, with the pupil, especially a constricted pupil, looking like a crater, and then the iris being draped over a very prominent, thick, and anteriorly positioned lens. And this takes on the appearance of a volcano with a very shallow central anterior chamber. And this also just suggests to us that the lens may be a very important mechanism leading to shallow anterior chamber and angle closure in this particular eye. Now, while on the topic of lens extraction and angle closure, we would have to talk about the EAGLE study. Now, in the EAGLE study, this is a multi-centered randomized controlled trial in which eyes were randomized into receiving either clear lens extraction or laser peripheral iridotomy. It is very important that we understand what types of cases are included in this study so that we do not over extrapolate the outcomes of this study to situations that are inappropriate. Now, first of all, these are all newly diagnosed primary angle closure cases with intraocular pressure of above 30 millimeters mercury or primary angle closure glaucoma cases. It is also very important to remember that all these eyes are of patients with age of 50 or above. So in other words, more or less, even though their vision is still very good, they may already have thickened lenses as well as already have developed some degree of presbyopia. Now, secondly, we must remember that all advanced cases of glaucomatous optic neuropathy were excluded from this study. Now, the important take-home messages from the EAGLE study is that, first of all, in terms of quality of life, the outcomes favor early clear lens extraction. And secondly, in terms of both the actual intraocular pressure level as well as the requirement for drugs, these outcomes also favor clear lens extraction as the initial step of treatment in such eyes. Now, so based on the above algorithm and clinical data, I think it is quite clear nowadays that lens extraction will often be the first intervention of choice in primary angle closure disease. But when is lens extraction alone not enough? I think there are at least two situations when lens extraction alone may not be sufficient. First of all, if there is very advanced glaucomatous optic neuropathy necessitating a very low target intraocular pressure. And secondly, if the intraocular pressure is grossly uncontrolled, in other words, there's a very high intraocular pressure and or very high dependence on glaucoma drugs, then in these situations, we may have to add something to the lens extraction. Now, this is my own personal preferred lens extraction treatment spectrum. Of course, you may add on other procedures depending on patient situations or surgeon's preferences, but this, what I'm showing you here, is my own treatment spectrum preference. So starting with phaco emulsification, if I need more intraocular pressure reduction, then the next step would be phaco combined with endoscopic cyclophotocoagulation. And after that, if I need even more IOP reduction, I'll do combined phacotrabeculectomy. Of course, as you move from left to right, there's increasing invasiveness, increasing surgical risk, as well as increasing surgical time. Now, the endoscopic cyclophotocoagulation is basically a laser technique that involves the application of laser burns onto the ciliary epithelium and thereby reducing aqueous production. And this is performed with an anterior chamber endoscope, which allows you direct visualization of the ciliary processes. Now, this computer simulation shows you how this procedure is performed. Usually after phacoemulsification, you keep the anterior chamber deepened for viscoelastic, and then you use an anterior chamber endoscope to directly visualize the ciliary processes, and then you apply laser to the ciliary epithelium. You can see that it appears that you are painting the ciliary epithelium white during the procedure. And it is very important that you make sure that the whole ciliary processes, including the valleys in between the ciliary processes, are all painted in white. And by doing this, you reduce aqueous production and lowers intraocular pressure. I think this is a very simple, elegant, and yet very effective procedure in lowering intraocular pressure alongside your phacoemulsification. Now, in this table, first of all, I must acknowledge that this may not be completely scientific, as I'm combining data from two separate randomized controlled trials. But I think this table does give you a rough idea as to how these three procedures compare with each other in terms of the several important outcome parameters. First of all, if you look at mean IOP reduction at 2 years after surgery, phacoemulsification alone actually is very effective. It reduces pressure by over 20%, whereas combined phaco-ECP reduces pressure by almost 28%, while combined phacotrabeculectomy reduces pressure by over 40%. If you look at the mean drug reduction at 2 years after surgery, then phacoemulsification, once again, you can see that by just performing phaco is very effective and reduces drug requirement by over 30% after 2 years. Whereas with phaco-ECP, the drug reduction approaches almost 50%, while with phacotrabeculectomy, the drug reduction is over 80%, which is very good. Now, in terms of surgical complications, of course, expectedly, combined phacotrabeculectomy is associated with a higher risk of surgical complications, whereas phacoemulsification alone carries a higher chance of requiring additional filtration surgery within 2 years after the initial intervention. So based on these data and based on these considerations, my personal preference is to start with phacoemulsification. If I need more IOP reduction, then I perform combined phaco-ECP. And if I need still more more IOP reduction, then I proceed to combined phacotrabeculectomy. Now, what are the factors to consider in deciding how far you have to go in reducing intraocular pressure? I think there are several important factors you need to take into consideration. First of all, is the preoperative intraocular pressure and drug requirement. You have to consider the stage of the glaucoma and also the target intraocular pressure you want to achieve. You have to look at the patient's age as well as the rate of progression of the disease in the recent few years. Of course, you also have to consider how much surgical risk the patient and the surgeon is willing to accept. And for this, you have to take into consideration the status of both the operated eye and the fellow eye, and also the patient's visual requirement for his or her work or hobbies. But I think most importantly, the final decision should be made after very thorough discussions of the pros, cons, and risk of each surgical options with the patient. So thank you very much indeed for your time. If you are interested in more contents on glaucoma or other subspecialties, please do take note of the first ever virtual APAO Congress 2021, which will be held from the 5th to the 11th of September later this year. And I do very much look forward to meeting all of you at the coming first ever virtual APAO Congress. Thank you very much indeed for your time.
I would like to thank the organizing committee and Asia Pacific Glaucoma Society for inviting me in this event. My name is Ika Sumantri, and I will present our study comparing phaco and phacotrap in management in primary angle closure glaucoma. I don't have any financial disclosure. As we all know that the first treatment of PAEG is laser peripheral iridotomy. Clear lens extraction is believed as an alternative approach. This technique offers benefit in relieving pupillary block, deepening the anterior chamber, and separating the anterior chamber angle with adhesions. Trabeculectomy is another option as the most common chosen in our region when the IOP is not controlled by medical treatment, but it may accelerate cataract, and cataract extraction performed after filtering surgery may lead to a reduction of bleb functions. Meanwhile, glaucoma and cataract, the preferred treatment option are phacoemulsification and IOL technique, and a combination of phaco and trabeculectomy. When we planning to have a surgery in a patient with a cataract and medically uncontrolled glaucoma, it becomes difficult to decide whether to perform trabeculectomy and phacoemulsification at the same time, or to perform phacoemulsification after trabeculectomy, or phacoemulsification only with gonocinihialysis. After trabeculectomy, it has been reported that axial length and anterior depth decrease and changes keratometry measurement with the result of unpredictable visual acuity. Meanwhile, doing phacoemulsification only is not easy and sometimes may occur. Similar to perform combined phacoemulsification and trabeculectomy, which mostly done by IOP, was not controlled even with the maximal tolerable medical treatment to achieve a certain target pressure. Treatment with phacoemulsification only has been shown to reduce the IOP in glaucomatous eye, especially in primary angle closure. Clear lens extraction in the PAECG eye can help to maintain visual acuity and improve the quality of life, reduce the need of wearing spectacles. This treatment in most PAECG eye, the target usually the IOP is up to 15-20 millimeter mercury. However, phacoemulsification only is not indicated for eye with Humphrey visual field mean deviation worse than minus 15 decibel or a cup to this ratio of more than 0.9. The efficacy of phacoemulsification in reduction intraocular pressure was proven not only in PAECG cases, but also in primary open-angle glaucoma and pseudoexfoliation. Based on what we found, at least 5 studies revealed the benefit of phacoemulsification in lowering IOP and adhesion. Meta-analysis by Armstrong et al. Found a 15-20% reduction of IOP and a reduction in the need of glaucoma eye drop by up to 58% in POAG patients after phacoemulsification. Meanwhile, Eagle study showed there was no efficacy was achieved of clear lens extraction performed when laser peripheral iridotomy. Another treatment option for patients with glaucoma coexisting with cataract is combined phacotrabeculectomy surgery. The indications suggest that with the presence of glaucoma coexisting with cataract, accompanied by the use of more than 2 eye drops glaucoma. And we have to see the severity of the disease and the eye which has fixation 3 times to the eyesight. and increasing the risk of glaucoma progressions. Anterior chamber optical coherent tomography, as it can be called, ASOCT, enable high-resolution visualization of the anterior chamber structure in vivo. Parameters of the anterior chamber angle that can be observed are related to the angle closer. First is narrowing of the angle, the anterior chamber width. It's shown in the picture on the right side, shorter in PRCGI than in normal eye. Second parameter that can be observed is the lens fault, which is also shortened. It can be observed as in the picture on the right. Another parameter observed in the ASOCT was a reduced TSA 500 area in the PRCGI compared to the normal eye, as shown in the image of the left of the screen. The broad view is indicated by the shaded area in the picture. TSA 500 or trabecular iris space area is 500 millimeter square area between the cornea and the iris. In addition, another parameter is ORD 500 angle opening distance. We conducted our study to evaluate the efficacy of phaco-only and combined phaco-trabeculectomy by assessing for outcome, namely intraocular pressure reduction, ASOCT parameter, postoperative best visual acuity, medical glaucoma reductions. This is our study, was a retrospective study with subject with patient with primary angle closer glaucoma with cataract graded up to 3. The following criteria inclusion were shown in the table, and the next table our exclusion criteria. The result as shown in this table, there was no significant differences in age, gender, and the mean preoperative visual acuity between the two groups. However, there were a significant difference in the mean preoperative IUP in the both groups. At the beginning of the study, the group that underwent combined phaco-trabeculectomy had a higher initial IUP. The following table presents the mean postoperative intraocular pressure result in first week, first month, and the first year follow-up. Both groups show a significant decrease in the mean postoperative IUP at first week, and also both groups show decrease in IUP at period of 1 month and 1 year, but not significant. The reduction of IUP was shown in the bar graph, as we shown here, and the success of the operation is classified into 3 categories, namely complete success, qualified success, and failure. Complete success was shown to be higher in phaco-emulsification group, as shown as the table. Unfortunately, there were still 2 cases of failure in the combined phaco-trab to preoperative failure. Here we try to identify several factors that may influence the greater post-combined phaco-trabeculectomy in IOP reduction. Our study found that the eye with peripheral anterior synechia greater than or equal to 90 degrees that had no change in the aqueous outflow facility when only lens extraction was performed. Furthermore, the long duration of formation peripheral anterior synechia will cause irreversible damage to trabecular meshwork. This suggests that lens extraction alone is still not sufficient to reduce IOP optimally. We believe this is one of the reasons the greater changes in the IOP were found in the group treated with the combined phaco-trabeculectomy. In terms of visual acuity, our study show visual acuity in the phaco-only group was better than in combined phaco-trab group. We further to next is the number. I think this is the number of glaucoma medication need to the 2 groups There was a decrease in number of patients receiving glaucoma medication by 90% in the phaco-only group. Meanwhile, there is a reduction of number of glaucoma medication in 89% in combined phaco-trabeculectomy group, but still more than 90% eye need glaucoma medication, mostly related to targeted pressure required. We compare to pre-op and post-op resulting using ASOCT, the first structure. Then we measure is a CCT, central corneal thickness, which we found not only significantly different between preoperative and postoperative value in both groups. Preoperative anterior chamber depth is illustrated in the left side of the image, and the postoperative LCD is displayed on the right side of the picture. It can be noted that the LCD is significantly improving, and it becomes deeper after the procedure compared to the slower preoperative period. This occurs in the phaco only on the left image and combined phaco-trap group on the right image. The following table compares the anterior chamber parameter assessed by anterior segment OCT, including the value of AOD, TISA, and SSA. The value presented is a comparison before surgery and 1 month after surgery in two groups. We found an increase in all anterior chamber angle parameter after surgery compared to pre-op condition in both groups. However, the result between the two groups is not significantly different. Furthermore, we also explored the correlation between the anterior chamber angle parameter and the decrease in IUP in PACGI. A significant correlation was only found between the lens fold value and reduction of in the IUP, and the rest of the other parameters didn't show any significant correlation to the decrease in IUP. Using ASOCT, we observed the change of profile the anterior chamber angle in primary angle closer glaucoma eye, namely by deepening and increasing the narrow of anterior chamber angle. The shrinkage of the posterior capsule increases the traction of slim canal and expand the tubular trabecular meshwork. So we clearly also glycosamina glycan deposit in the trabecular meshwork structure. This all support to achieve PACGI in IUP reductions. Bigger IUP reduction is found in phaco-trabeculectomy group. The advantages of the combined cataract and trabeculectomy surgery are glaucoma and cataract can occur simultaneously or later due to the person's age and long-term use of glaucoma eye drop. When doing in cataract in glaucoma PACGI with a compromised optic nerve, this surgery will avoid IUP spike after surgery. There are also potential for long-term IUP control and quick visual acuity recovery, and also reduce cost due to a single visit. Whereas in disadvantages are more intra or post-operative complication, longer visual recovery, surgeon will face difficulty of doing the surgery such as small anterior segment which is near to endothelial cornea. There is also a small pupil or pure pupil dilatation. Posterior synechia make cataract extraction more challenging. So, risk of vitreous loss during cataract surgery may lead to failure of glaucoma surgery. As conclusions, there is an IUP decrease post-operatively in both groups. Combined phaco-trabeculectomy appear to have greater IUP reduction. There was significantly different in visual acuity and post-operative between the two groups due to the combined phaco-trap has more advanced stage of PACG when compared to the phaco group only. We suggest phaco emulsification only in better perform in early stage of the glaucoma. Yeah, thank you.
Thank you for all presenter and for the nice and very insightful presentation. Now we will start with the discussion. Please, Dr. Fira. Unmute, Dr. Fira. Please unmute your voice.
Okay, sorry. So we already have a couple of questions in the Q&A box and the chat box. And fortunately, Professor Sang Kyung Fang already answered those questions. But I think I would like to elaborate the question in the Q&A box regarding if we don't have a laser facility for the patient in acute angle closure. Do you recommend doing a surgical iridectomy, Prof?
Is it directed to me?
Yes, please, Prof.
Yeah, I think we have not need to do surgical iridectomy for a long time because most of the measures that I have mentioned will be able to manage to break the acute attack. So I would like to hear from others as well. Maybe Clement.
Hello, yes, thank you very much for the question. I agree with Sang Kyung that the last time I did an emergency surgical iridectomy was probably 20 years ago, because nowadays there's so many options. Medications, including systemic medications, remain a very effective means for lowering intraocular pressure. If you have laser facilities, I think laser iridoplasty is very effective and very safe. Apart from these two, I understand that some people are also doing anterior chamber paracentesis. In fact, our group has published a paper on using this. This technique reduces pressure very rapidly, relieves the severe symptoms very rapidly, but of course, it is an invasive procedure and it carries the small risk of, say, for example, infection, hemorrhage, etc. And so nowadays, our group does not do it routinely. But I'm fully aware that there are many other centers that are using anterior chamber paracentesis on a routine basis. And I think one of the strongest advocates for this is Professor Paul Palmberg at the University of Miami. He does this for every acute angle closure glaucoma patients. In our group in the past, when we did anterior chamber paracentesis, we used a 15-degree knife. Just like when you perform paracentesis during phaco surgery, I think for most of us who are regularly performing phacoemulsification, the technique we're all very familiar with and is relatively safe. As for Professor Palmberg, I understand that he used a syringe. I think he used a 30-gauge needle to enter the anterior chamber. And according to him, the aqueous will drip out very slowly. And as soon as the dripping stops, the pressure is in the low teens or perhaps in the high single digits. So this is, of course, another possibility if laser is not available. Because there are so many options nowadays, I think the chance of having to do emergency surgical iridectomy is very minimal.
I think the question was what to do if you don't have a laser. So, I don't think the question was to break the acute attack, but it's a long-term treatment of the acute attack after it's broken. So, I think the surgical iridectomy is an option if you don't have a laser, because what Professor Pham was saying is about paracentesis is just to break the acute attack. But after you break the acute attack, you still have to do the definitive treatment.
Yes.
So I would agree with the question that if you don't have a laser, surgical iridectomy is an option. Or a better option would be doing phacoemulsification if you're capable and if you can do it, and the eye is quietened down. But if you can't, then I think surgical iridectomy is a fair option. Yeah.
Well, thanks very much, Tin, for clarifying the question. Yes, I agree with you completely. If once the pressure is well controlled, you're talking about the next stage of treatment, which is to prevent the progression to the chronic form of the disease and also to prevent a recurrence of the acute attack. I suppose surgical iridectomy, I wouldn't say it's not an option, but once again, it's been a long time since our group has to perform a surgical iridectomy as the next step in the management. I think in that situation, if laser facility is not available, I personally would have a relatively low threshold for performing phacoemulsification. Of course, if there's any degree of visually significant cataract, I think the cataract should be taken out. In the rare circumstances when you feel that the lens is completely clear, which I think is relatively rare, then there are certain indications that I may still consider clear lens extraction, and that would include a poorly controlled intraocular pressure, or if the anterior chamber is very shallow and you feel that the lens is certainly a very significant contributor to the angle closure, then after thorough discussion with the patient, I still think clear lens extraction could be considered. But thanks very much, Tin, for clarifying the question.
Yeah. Also, another point, if you don't have a laser iridotomy, I worry you may not even have a phaco machine. So, that's the other consideration. And so, perhaps a surgical iridotomy may be the safest option at the moment. And later on, do the lens extraction. It's much quieter when it's much safer. Because, if you don't have a laser, you may not have a phaco emulsification either. So,
true.
Maybe that setting, you have to consider that setting.
Yes, Prof. I mean, usually we have that, that because Indonesia is like a very there are many islands, and the transportation is not that easy. Maybe it will be helpful for the ophthalmologists who live or stay in the very remote area with not a very proper facility like in the big city. If it is in big city, maybe we will have the laser or we will have the phaco emulsification machine. But for the more remote area, it will be like very difficult to have that. So at the meantime, before the patient was referred to the other ophthalmologist who has the facility, maybe the surgical iridotomy is an option. Is it the conclusion?
I think so. It's reasonable. Yeah. And there's a question about after paracentesis, how long should you wait? And I think, paracentesis is only a temporary measure. So, in some cases, you do paracentesis, it may break the cat for a while, and then the cat can come back in half an hour, So it's only a temporary measure. Once the cornea clears up, you have to do the definitive treatment, either the laser PI, as soon as possible. Yeah. So I worry that if we do paracentesis and you don't do a definite treatment, it may come back again. Yeah, the attack may not resolve completely.
Or maybe, may I ask, in those situations when you really have to do a surgical iridectomy to prevent future recurrence, what usually would be the next step in those places? What do you do next after the surgical iridectomy? Because sooner or later, there will be some cataract.
Yes. Usually they will refer the patient to the other ophthalmologist, especially to the glaucoma specialist in the big city. Because it takes time. Yeah, it takes time to send the patients. If we don't do like the Prof. Ongtin said, that we do the surgical iridectomy to at least to maintain the IOP for a moment. Then after it is like safer, then the patient could go to the other facilities to do the maybe phaco emulsification or other procedure like that.
Yes, thank you. I think that sounds like a very reasonable approach.
Well, can I add some comments to that surgical iridectomy? Well, I do agree with Tin and Clement about their comments, but I would like to acknowledge you that surgical iridectomy is not an easy task. Especially in the hot eyes, and we have to calm down the eye for a little bit before we take the patients into the OT to do the surgical iridectomy. And during the procedure itself is not just as easy as just we have ever imagined. So that's why I would like to make some points on that. Thanks.
How about if I have experience, if we have such a acute angle closure glaucoma, we usually give the medication, of course, and then I think we can do the paracentesis. After that, can we do the trabeculectomy instead after the eye quite clear? I think we can do a trabeculectomy, but then a patient can go to the proper hospital to do another step of the treatment. I think that's the one of my things. I don't know, because that usually happen in our regions. They usually do, maybe we have to reduce the IOP, and then maybe we can do paracentesis, trabeculect, and while the eye already clear, and there is no hot anymore, so we can proceed with the procedure of trabeculectomy. And then if they need to do the cataract surgery during phaco emulsification, they can send the patient to the bigger hospital. I think maybe that's one in our regions. I don't know.
I think,
What do
in
you think
Singapore,
about that, Prof. Tin?
yeah, in Singapore, when I was a resident, there was many doctors who used to do that. They used to do trabeculectomy as a first option. But I think there are a lot of complications can occur, number one, and often because they're very hot eye, trabeculectomy is not going to work. It'll fail quite quickly. So my preference is not to do a trabeculectomy, but if really have no option, then you have no option. But as the comment was saying, a phaco emaciation, once the eye quieted down, is probably the better operation, and then you can do a trabeculectomy later if there's a very bad chronic angle closure glaucoma or is acute on a chronic attack. But if you can do the phaco, I think it's probably better. But if you cannot, no other option, then trabeculectomy is the option. But there's also lots of complication, and they probably will fail after a while as well.
Okay.
Okay.
Thank you.
Thank you.
Okay. So there's another question in the Q&A box, but already answered by Prof. Ang Tin. I have a question to the speakers, specifically to Professor Clement Tam and Prof. Ike. As we know, the complication of combined procedures such as phaco trabeculectomy is quite high. What can we do to minimize these complications? And also, do you think it's better to do both procedure in one setting, or do you do it consequentially? Thank you.
Okay, Prof. Tan.
Thank you. You were talking about phaco trabeculectomy, right? Yes. To me, usually, I think phaco very often features as an initial procedure unless I have special reasons not to do it in the primary angle closure glaucoma case. The question is really what you add to the phaco at the same setting. Okay, so for those cases in which the glaucomatous optic neuropathy is not very advanced, the pressure control is not too bad, I usually perform just the phaco alone. If I need more intraocular pressure lowering, or if I need more IOP drug reduction, or if the nerve is very advancedly damaged, then I may consider adding something. And usually for myself personally, my next step would be combined phaco and endoscopic cyclophotocoagulation. Okay, and if I need further IOP reduction in even more advanced cases with even worse IOP control, then I'll proceed to phaco trabeculectomy. So you can see it's a spectrum. And from phaco to phaco ECP and then to phaco trabeculectomy, there is increasing invasiveness, increasing power of IOP reduction, but at the same time, increasing surgical risk and risk of complications. I'm aware that, in fact, I mentioned this in the World Glaucoma Congress recently, and some of my fellow faculty suggested that perhaps for the middle step, you may consider mix. Some of the mix may be amenable in conjunction with phaco emulsification in certain angle closure cases. And of course, that is very much a surgeon's preference, but I think the same thinking lies behind it, because you should have a spectrum of surgical treatment by combining different procedures for phaco, depending on how much IOP reduction you need and how low a target pressure you want.
I don't think the phaco mix is a good option because I don't think the efficacy is good. And from the data we've seen so far, it's not good. Yeah, and you're just paying a lot of money and not getting any return. Yeah, I mean, I think it's very controversial for angle closure. And some of the colleagues who've done phaco mix, the mix gets clogged up by iris because of the the angle, the anterior chamber is shallow and there's iris there. So I wouldn't recommend that. I think as Clement was saying, phaco alone is a very good procedure. Yeah, it does very well in many angle closure cases. And the phaco mix studies, they may show 6 millimeters of lowering, but phaco alone may show even more. Yeah, so I mean, I don't think I would recommend phaco mix. Yeah.
Yes, thanks very much for this important comment. In fact, in our setting, we don't do phaco mix for the simple reason that in our public service, we feel that the cost effectiveness of mix, the amount of money you spend per millimeter mercury drop is far too low. Yes. In our setting, we basically don't do it. But I agree with you that so far looking at the literature, the results are not so promising either.
For POAG, I think it's not too bad, but I'm talking about PACG. Yeah?
PACG, yes, we're talking about PACG.
Well, can I add something like, for phaco in the angle closure? I think we've got very small studies 10 years ago published in the local journal about phaco alone in the not extensive PAS of the in a PACG with not extensive PAS, which means that less than 180 degrees compared to so with a control, right? And we found that it's quite favorable for the phaco alone in the PSCG eyes that has PS less than 180 degrees. So I think that would be, if you so it depends on the stage of the PSCG. It depends on the PSCS that you have. So that's why you have to go with the phaco alone or other things. And for the phaco mix, I agree with you. It's a very, very, you have to be very careful when you have to do some kind of, particularly for the subconjunctival mix, because if somehow the angle is not wide enough, if you even take off the cataract, and then when you put some mix in, and if you do not do the gonioscopically examination first, and then you might get the peripheral iris into that, when you piercing through the sclera, the hemorrhage things and everything, and later on the mix itself may be occluded by the peripheral iris. That thing that why in the PSCG with mixed, you have to be very careful on choosing the mix. That's it. I'm not sure.
To Dr. Visani's point, we also did a study comparing phaco versus phaco GSL, and these are people with 6 clock hours of angle closure, at least 6 clock hours of PAS. And even in that group, we were surprised the phaco group did very well. Okay, so even with extensive angle PS, the phaco alone did very well. In fact, they did as good as the phaco GSL. So we were very disappointed. We thought phaco GSL would do better, but we found it the other way around. So even with a lot of PS, somehow phaco alone does pretty well. So I mean, it's something we should consider as a first trial, as Clement was saying. Do it first and try to see how it goes.
No, my comment on that is that when you are performing phaco alone, you are inadvertently performing some semiculitis.
Exactly.
Yes. Thank you.
Yeah.
Can
I ask Clement? Can I ask Clement a question?
Sure.
The time already up, Professor. I'm sorry.
We have limited time.
Okay.
It is actually very, very nice discussion. I really enjoyed this session. Thank you very much from APGS for coming to our session for Indonesian Glaucoma Society National Glaucoma Meeting. Thank you very much. I will close this session, and hopefully next year and next 2 years, every 2 years we will do this. We could have this meeting again. Thank you very much.
Thank you. Take care.
Bye-bye.
Bye.
Take care.
Bye.
Stay safe, everyone.
Stay safe, everyone.
Bye.